So I'm going to talk about the ALCOVE work package on the rights, autonomy and dignity of people with dementia. And I'm making this presentation on behalf of the King Goldman Foundation, in particular Gombo, who was unable to be here today. And they managed this work project, and so I'd like to acknowledge them. A critical review of the medical legal literature was carried out by Professor Herman Nice and his colleagues from the University in Leuven, and the bioethical literature was reviewed by the Espace Éthique of the Assistance Publique Hôpitaux de Paris. 3 international workshops were held to discuss the findings from these reviews and to draft recommendations, and I was involved in these workshops on behalf of Alzheimer Europe. So the main topic of the work package was the assessment of competence and the use of advanced directives to help promote the autonomy of people with dementia and provide them with protection. The recommendations cover the legal, ethical, but also practical issues linked to competence assessment and the use of advanced directives in the context of advanced care planning. Advanced care planning, just to define it, could be described as a process of communication, discussion, consultation, and decision-making between an individual, his or her care providers, and other possible relevant persons concerning future care and the treatment options for that individual. Advanced directives are written or oral statements regarding positive and negative decisions, and they enable people to express wishes and their will in advance of incapacity or of the inability to express decisions, and may or may not include end-of-life decisions. So in this presentation, I'll briefly summarise in the next 2 slides the legal status of advanced directives based on Professor Nice's survey, and then focus on some of the issues linked to the ethical use, drawing on the ALCOVE study. So with regard to the legal status of advanced directives, 15 countries have legislation on advanced directives, not specifically for people with dementia, and 10 of these were approved after 2005, so we're talking about fairly recent legislation. 7 of the countries which do not have legislation have ratified the European Convention on Human Rights and Biomedicine, and this does not address advanced directives as such, but acknowledges them indirectly as formulations of previously expressed wishes of the patient. So Article 9 provides that the previously expressed wishes relating to a medical intervention by a patient who is not, at the time of the intervention, in a state to express his or her wishes shall be taken into account. And given the direct applicability of Article 9 of this convention, the legal validity of advanced directives in these 7 countries is, according to Professor Nice, beyond discussion. So collectively, this means, as just mentioned, that the legal validity of advanced directives is recognised in 22 member states of the European Union. And of the 2 of the 5 countries without specific legislation and which have not yet ratified the convention, they are in the process of approving such legislation. To make a valid advanced directive, a person must have the necessary capacity to do so. But even if they lack legal capacity to make a new one or amend one, they can often still revoke an existing one, even through behaviour which clearly indicates the desire to do so, as a higher level of capacity is required to make an advanced directive than is needed to cancel one. On the other hand, at some point the person with dementia may lack awareness that he or she has even made an advanced directive, or no longer understand what is in it or be able to communicate effectively. Wishes may be legally binding based on a refusal of treatment, sometimes dependent on a person's prognosis. For example, it might be stated that the person must be terminally ill or have no chance of recovery, or they may be advisory based on requests and preferences which must nevertheless be taken into consideration. Physicians may also take into account circumstances not known by the author or that have changed since the advanced directive was drafted. And sometimes, to be valid, an advanced directive must have been written or reviewed within a specific time period, for example 2 or 5 years. The most complex ethical and legal issues tend to arise with an advanced directive made by a person with dementia refusing a medical treatment. With regard to some of the ethical issues of relevance to dementia and the use of advanced directives, the dignity and identity of all human beings must be protected regardless of their medical condition. Respect for and the promotion of personhood is also of vital importance and sometimes threatened through negative perceptions of dementia. Autonomy is a key principle in biomedical ethics, and respecting a person's rights, choices and preferences is crucial, but in the case of dementia raises difficult ethical issues because the person's capacity to make informed decisions typically deteriorates over time, and even though there may be some fluctuation, bearing in mind that capacity is task or situation specific, so a person may have capacity to decide in some situations but not in others. The autonomy of people with dementia should be respected at all times, but other principles such as beneficence, justice and non-maleficence should also be borne in mind and balanced with respect for the person's right to self-determination. But in addition to the biomedical ethical principles, attention must also be paid to more care-related ethical issues, which focus, for example, on individuality, well-being, personhood, the person's history, and his or her relationships with other people. The availability of high-quality care following timely diagnosis and legal provisions is a prerequisite for achieving this goal, but striking the right balance is not only a question of care models or laws, but also, and more importantly, one of listening to and understanding people with dementia. Issues linked to dignity, identity and personhood may sometimes be linked to a failure or difficulty to hear the voice of the person with dementia and to understand his or her experience of dementia, but often accompanied by a certain fear and stigma, involving, for example, stereotyping, devaluation and discrimination. Respecting individuality also means understanding what makes a person unique, including their wishes, fears, values and preferences. Advanced directives may contribute towards autonomy by giving people an opportunity to make decisions whilst they still have the capacity to do so. And this may contribute towards well-being by providing reassurance that the person will be protected from unwanted treatment and or not be denied available treatment which he or she would have wanted and which would be clinically appropriate at the given time and situation. In the more global context of ongoing advanced care planning, advanced directives help ensure that the diversity of personal wishes, social values and cultural practice backgrounds, as well as the current cognitive and functional capacities of each person with dementia, are conveyed to formal and informal carers. The recommendations also emphasise the importance of noting care preferences, values and statements about what is meaningful in life. Depending on the formalities in different countries, this might be in the Advanced Directive or it could be in a separate attached document called a Statement of Values. As people with dementia may spend quite some time in residential care or receiving home care, it's equally important for them to be able to express in advance of incapacity things that are important to them in life and things which may even seem quite trivial to other people but which may have a huge impact on their quality of life. An advanced directive can also serve to promote autonomy through the appointment of a proxy decision maker for all or certain decisions or to be consulted regarding the interpretation of advanced directives. And this helps avoid situations whereby people are consulted solely on the basis of their relationship to the person with dementia, but who are not actually sufficiently familiar with that person to know what they would have wanted, or they may also be reluctant to make such decisions. There may be cases where the person with dementia would not want people to be consulted, perhaps due to conflict, strong differences of opinion, or the desire to protect people from the burden or emotional strain of having to make difficult decisions at a very difficult time. So having a self-appointed proxy can also be helpful in cases where there is uncertainty as to whether the person's wishes correspond to the current situation, perhaps due to considerable medical advances having been made since it was written, or in cases where the wishes are unclear or ambiguous. And this can also be sometimes the case where the statements are actually too specific or too general. Advanced directives may in certain cases promote the well-being and provide peace of mind for carers. They facilitate the task of carers to comply with the obligation or moral duty to take into consideration the wishes of the person with dementia and to feel satisfied that they're providing the kind of care and treatment that the person would have wanted and would not object to. They may also ease the burden of making difficult decisions, for example, about residential care or artificial feeding or hydration, at a time when the relatives or close friends are under great emotional strain. And they may help avoid dilemmas and resolve conflicts between and amongst carers about what the person with dementia would have wanted. If advance directives are to promote autonomy, they must have been written when the person had the sufficient and relevant capacity to do so, and only be used when the person in question lacks the necessary capacity for a particular decision at a particular time. Otherwise, they could result in decisions being made which do not reflect the wishes of the person with dementia and are even detrimental to the person's well-being and in some cases even life. And this raises challenges with regard to the assessment of capacity. In the recommendations of the ALCOVE report, a few key priorities are highlighted regarding the assessment of capacity, including the need to ensure that a diagnosis of dementia does not result in a person being automatically considered incompetent, that competence should be assessed on a case-by-case basis and repeated for every important care or treatment decision. Competence regarding care and treatment should be assessed by qualified and skilled healthcare professionals, and additional research on the development and validation of efficient and practical assessment tools is needed. Advance directives are not yet widely used by people with dementia, and there are a few challenges in this respect. For example, there is a historical association between advance directives and the end of life. Advance directives are often associated with life-threatening diseases such as cancer or heart disease, cover emergency situations where patients have lost consciousness, or refer to prolonged states of unconsciousness. The situation is different in the case of dementia. Depending on the stage at which a person is diagnosed, they may have been living for 5 or 10, 20, even more years with dementia. And during this time, their mental capacity will gradually and progressively deteriorate, and this will affect their ability to make decisions. At various times during the illness, situations will arise when care and treatment decisions must be made, which are not all linked to the end of life, but may have implications for the person's health, well-being and safety. Another challenge is the perception of dementia as a stigma, the stereotyping of dementia as consisting solely of the end stage and the fear of dementia. And these factors may make people with dementia, their carers and healthcare professionals reluctant to broach the topic of advance directives. Another important factor is time. People must have the relevant capacity to make an advance directive, so late diagnosis may prevent people with dementia from doing so. And for an advance directive to serve its purpose, it must be known about, so it's important that there's some kind of system in place to ensure that they arrive in the hands of the right people at the right time, and that any system should not be too bureaucratic or costly that it dissuades people from using it. And finally, this is more of a philosophical issue about the status of being a person. It has been argued that some people with dementia may change so radically in the course of the disease that they no longer seem to be the same person, and hence their previously expressed wishes should not be binding on their current situation. However, people must be aware that their experience of dementia may not be as they expected or even feared, that the experience of dementia may affect what they feel is important, and this should be part of discussions around making an advance directive, and attempts made to ensure that the person's wishes have not changed and to maximise the potential of the person to express their current wishes. In its earlier work on advance directives, Alzheimer Europe emphasised the importance of not only using an advance directive when capacity for a particular decision was lacking, but it does not support statements which suggest that people with dementia ever lose the status of person, regardless of the stage of dementia. So despite the development of a legal framework for the use of advance directives by people with dementia, amongst others, they are still not widely used. If made when a person has capacity and only used when they do not, they do have the potential to contribute towards the self-determination as well as appropriate protection of people with dementia. The ALCOVE report outlines the main legal and ethical issues related to their use and can be downloaded freely from the King Baudouin Foundation website and also from the ALCOVE website. Alzheimer Europe has also developed guidelines on advance directives and has a sample form in several languages which can be obtained from Alzheimer Europe, and the Finnish Alzheimer Association recently developed another advance directive based on our earlier work, and this has also been translated into English and can be downloaded from the Finnish website. And finally, there are initiatives exist in several EU member states to develop instruments for advanced care planning, specifically aimed at people with dementia and their carers in various care settings. To conclude, advanced directives represent a considerable step towards the promotion of autonomy and the protection of people with dementia within the overall context of advanced care planning. but their benefits extend beyond this to potential benefits, to both personal and interpersonal issues linked to well-being, dignity, identity and relationships.